Good morning. Today we are very pleased to have Dr. Astik Joshi and Dr. Lee Stevens here presenting motivational interviewing for us. This is a very important topic getting more and more emphasis in our daily clinical encounters. And Dr. Joshi is about to complete his child and adolescent psychiatry fellowship here in our institution. He has strong interest in psychiatric comorbidities of chronic disease, such as diabetes. And that was one of the reasons he just completed a 1-month rotation in our division. And today, this talk actually originates from our discussions during his rotation. And again, Dr. Stevens is the vice chairman of the Child and Adolescent Psychiatry Fellowship Program here. Many more to say on their CVs, very accomplished, but I will keep the introduction short to leave more time to talk to us. Thank you.
Right. Can you all hear me? Fine? Okay. So thank you for the introduction, Dr. Gangur. And thank you for letting me, giving me a chance to talk. And thank you people for showing up. It's early. I'm going to be talking about motivational interviewing in the context of teenagers. I feel we need to address that, and that's why this topic came to my mind. One of the reasons I went into a pediatric subspecialty is because I feel we've all been there. We've all been teenagers. Somehow I can't relate to the population I can relate to teenagers, and I feel we all can. It's an extremely important tool to have in your knowledge base if you can if you know the skills of motivational interviewing. I'm a PGY-5. I'm about to get done with my child fellowship. I'm going to be starting my psychiatry and law forensic fellowship soon. So this talk is going to be about something we know and practice in our daily lives, but this is more about connecting the dots of things we already know. And just the way to go about it. So I have no conflict of interest. Thank you, Dr. Stevens and everybody else in our faculty. Thank you, Dr. Horton, Dr. Barnes, Dr. Booker for showing up, Dr. McBee and Dr. Gungur to give me a chance. The goals and objectives of this talk are to better address compliance issues with our patients. It can be used as a tool, which can be used in a brief visit. You don't need hours to do motivational interviewing. You just need to get the skill. And if what we call resistance or denial, or the patient calls whatever, but it's a useful tool to overcome that. I'm going to start off with a quote because I love quotes, and love this quote by Socrates. The only true wisdom is knowing that you know nothing. It's really important we don't bias ourselves before we see the patient. I feel that's a lot of it is going on. Clustering patient is useful, and it's a clue, but it can cause problems. You need to remember it's just a piece of the pie. It's not the whole thing. And you got to look out consciously for untold clues. Let me see if we have any other. This is giving me problems though. I think the presentation is not going through. Oops. Anyways, I'm just going to continue. So we have writing reflex in medicine. What it means is we see the problem, we want to fix it, and subconsciously we say that I'm right and I know what I'm doing, and the what the patient hears is I'm wrong, and it attaches this negative emotional state and results in shame, guilt. They feel put down. If you have ever been put down, you can kind of understand from the patient's side. That's what we call resistance or denial. The treatment is compromised and the patient is the one who bears the consequences. We have 3 definitions of motivational interviewing given in the 3rd edition, which came out in 2012-2013. It's by Miller and Rodnick. And they said one is elevator definition on the laypersons, one is practitioners, and one is technical. So the layperson's definition would be, they all pretty much mean you collaborate with the patient and you have a conversation and see where they are coming from and guide them towards the medically right thing to do. Further explaining, it focuses on the language of change. What language of change means is to recognize the patient's motivation to change behaviors, and we need to know what the patient is thinking, and that's really important. And for that, we have to give them the warm environment. This is idealistic, but if we can, we need to show an environment of acceptance and compassion. Establishing rapport or therapeutic alliance can be really useful. What happens is, if we don't have that alliance, the patient doesn't relate to us as well and might not follow the recommendations. And then after we get the history, we give them tools to help themselves. It was first described in 1983. It first came out in the literature in 1983. And at that time, it was useful for substance abuse and alcoholism. And it is now mainly practiced for substance abuse, eating behaviors, /obesity, and it's being used in the prison population. The characteristics include, and this is by the literature, it includes identifying intrinsic values. We got to know that change is elicited from within, not without. We want to get the patient ambivalent, and ambivalence means, I'm going to be using this word a lot. So ambivalence or discrepancy would mean something like a patient hypothetically wanting to be a rocket scientist but dropping out of school and smoking pot every day. So let them say that in a sentence and focus on it. And we gotta know about the ambivalence and address it at that point. Readiness to change, we see how much the patient wants to change, and it's an observation. Patient's resistance is a clue to change treatment strategy. By that, what I mean is, if a patient gets into that defensive mode or that resistant or denial mode, you can either change the topic and come back to it later or dig further in. And sometimes it helps just to not concentrate on that and change the topic. You want to get the patient self-confident. You want to give them tools to be confident themselves to change the things they need to change. Respect patient autonomy, and this is more of a guidance style more than a direct persuasion. I want to touch on biopsychosocial understanding of the patient. I feel we need to understand what the overall broad understanding of the patient is. And motivational interviewing is going to help us with that. What biopsychosocial understanding means is you evaluate the patient from the biological, psychological, and the social aspect. We do a good job at the biological aspect of it, which includes family history, compliance with meds, response to meds. What we need to understand is, there's psychological and social factors to it. So I'm going to give a hypothetical example. So if we have a teenager with supportive family who has a good doctor who gives the right medicines and they don't use substances or their coping skills are exercise, etc., versus somebody who doesn't have a supportive family, doesn't go to a doctor, and uses drugs. And we know where the prognosis is heading. So just sitting back and looking at the patient from all three aspects would help us better give the treatment, right treatment for the right patient. So motivational interviewing is not advice giving, it is not direct persuasion. It is more of sitting back and letting the patient talk and intervening when necessary. Research has shown that using words like obesity it has a negative connotation to it. And sometimes reframing it as right eating habits or balanced eating habits or weight loss exercises. Obesity is a disease, but eating problems, not all obese patients are going to get sick. We need to realize the ones that are going to be, that they're going to get sick, and we need to change whatever is needed, the eating habits or the exercise. That's where we intervene in. I think it's really important for diseases to understand some invisible diseases, what that chronic invisible illness is. By that I mean diseases like epilepsy, which comes to mind, diabetes too. On their side, they are taking a drug, say Depakote or Keppra. They are taking drugs to address something that doesn't affect their daily lives. They are taking Depakote, Keppra, all these drugs. The anti-seizure drugs have their own side effects, and they take something which gets them drowsy, affects their cognition, and for something which really doesn't happen every day. And we need to understand that. Explaining the medicine and the disease via a way of pros and cons helps a lot. By pros I mean, what are the pros of taking the medicine? What is in epilepsy? What are the cons? The side effects? What is the pros? You're gonna stop the seizure from happening. Summarizing it towards the end of encounter, when we talk to the patient, we usually give a lot of information. And a lot of times when the patient gets out of the appointment, all they remember is 1, 2, or maybe nothing. So towards the end of it, summarizing it with 1 or 2 points, telling them the take-home message is this and this. Eat right, don't smoke, and that helps because that gets into their mind. We want to address the high-risk behaviors, and for that, motivational interviewing could be used. Questionnaires are useful too. So let me talk about the brain for a little bit. When the puberty begins, that's when a lot of behaviors which, until puberty, the patient, let me say this, so brain changes, they occur at the onset of puberty, and that's when the substance abuse risk starts, that's when the non-compliance or non-adherence starts, because their lives become more believable. How that happens is because they have a white matter spurt right behind where your eyes would be. It's in the prefrontal cortex, it's closely connected to the orbitofrontal cortex, and there's a white matter spurt which kind of buffers the response of their sensory and the motor system. So and the connections get more fluid. They can make their lives more believable. How do I know this? Because they studied in the prison population, and they saw that they had 20 to 25% more white matter hypertrophy in criminals than people who were not convicted. And that kind of helps with the abstract thinking. Bipeds, I don't know if, it's out there in the literature. How you can use this is you give, when the patient is out in the waiting room, you give this to the patient and or the parent and have it fill out. What it helps with is the high-risk population. It would tell you what to focus on specifically. Body image, that's their eating behaviors. Home environment is abuse, education, activities, what kind of coping skills should they use, drugs, alcohol, sexual behaviors, and suicide and safety assessment. We got to understand that physician is the one who offers the opinion. Patient is the one who acts in their best interest. We want them to communicate the level of readiness for change. And what we do is we develop discrepancy. Again, that same hypothetical example about where they are and what they want to be, and what's their plan to go about it. 3 functional model, that's one of the models that's used. I mean, we can all relate to it. It's gathering data, history taking, managing the flow of information, and then educating the patient and negotiating the treatment plan. Gathering data, some specifics about it. Gathering data would be, it's better if you ask open-ended question. What's an open-ended question? It's more like, tell me about your diabetes. What's a closed-ended question? What's your telephone number? That's specific. Managing information flow, a good way to go about it would be saying something, hypothetically, if you think about a 16-year-old female, and you ask her if she used condom in her last sexual encounter, and just sit back and see what the patient thinks. They're gonna think, my mom would kill me, I might be pregnant, I might have STD, but you're gonna see it. You're gonna see the guilt and the shame if you ask such a question and just sit back and intervene at the right time. It's important to show compassion. They're already feeling the guilt, so you don't want to press on that aspect of it, but intervene and ask something like, what kind of birth control do you think would help you the best? It showed up all wrong, the presentation, so. Anyways. I'm just going to go along. Okay, so the trans-theoretical model of behavior change. It was mainly developed for substance abuse. It has 6 stages: pre-contemplation, contemplation, preparation, action, maintenance, relapse, or recycling. And these stages, what these stages mean is, if you ask somebody if they are planning to quit smoking, a person in pre-contemplation stage would say, you would know they don't want to do it. They haven't planned for it. They don't want the change. They would come up with reasons. And on the literature, it says they're not going to take any action for the next 6 months. Contemplation would mean they've thought about it some. A lot of patients are going to be in the contemplation stage. They intend to take action, but they're not that motivated yet. Preparation would be, to me, it is, they have a plan. They say, I'm gonna quit smoking on the 21st of the month because it's my daughter's birthday. It's more concrete. Action or maintenance is, action to me is they've quit smoking. It's in the next couple of weeks. They've just quit smoking. They're at a high risk of relapse, and maintenance would be, later on. What we can do is we can tell them that it's a marathon, it's not a sprint. It's tough for them, and we have to realize that. The 6th one, you have different terms in the literature: relapsing, recycling, and termination is when you stop it, which is highly unlikely. our role in that. Pre-contemplation, we are able to find that the patient is not that motivated. So what you do is you schedule the follow-up and at least give the information. This is what the data shows. This is what smoking can do to you. This is what drug use can do to you. And you want to schedule the follow-up appointment sooner rather than later, because high-risk behaviors has its own really bad consequences. Chronic illnesses and something acute like suicide or something like just drunk driving. Contemplation would be, what we do is we discuss the pros and cons. We tell them, if you quit smoking, what are the good things you'll experience? Maybe, and what are the bad things? So cons would be something like, it relaxes me. So that's what I'm going to miss. Pros would be, it would give me more time with my family. Preparation is when you, in preparation, you get more concrete. You build up goals. You have that discussion of plans. And again, with the high-risk population, you want to follow up sooner rather than later. Action or maintenance stage, they have daily struggles, and we got to understand those. So what we can do is we can tell them to maybe avoid going through the road that has the same liquor store they go to every day, and you want to solve their problems specifically. In relapse, you want to normalize that, because they do have a lot of shame and guilt, and you want an environment where they can tell that to you, and you say that it's very normal, and you tell them that going back to the first stage is highly unlikely. Most likely they're going to be in the last 3 stages. Neurobiology. I love the neurobiology. It shows us why we do what we do. And let's talk about the brain. The growth starts soon after conception. That's why it's really, the first trimester for brain growth is really important. And drug use and behaviors, unhealthy behaviors, affect the brain growth of the child that's going to be born. So I think about the brain as a sort of a moldable clay which gets solidified later on in life. So the first 10 years, it's highly neuroplastic. That's why we need the right nutrition, the right habits in the first decade of life. Rate of growth starts to decrease by puberty, and that's where the bad behaviors come in. The shaping of the brain happens in adolescence. That's where the brain takes shape, and the things we don't need is cut off, the things we need are grown more. Also called synaptic pruning. Many people don't know this, but it continues to grow at a high rate until 25 years or more, and the neuroplastic changes continue throughout. What separates humans from other species is the prefrontal cortex, and we have a larger prefrontal cortex. It is one of the last areas to develop. We need to take it in context of the adolescent. So a 16-year-old still has the prefrontal cortex developing. They don't have the connections made. And prefrontal cortex is kind of the boss of the brain. It directs the other parts of the brain, and it needs to have a good circuitry for it to do that. It's not until their 20s that the prefrontal cortex functions at its best. There's a lot of role that's been in research recently. There's a lot of role for ventral prefrontal cortex. It helps with decision making, emotional regulation, delayed gratification, and thought process. How we can use that in adolescence is, it's still developing. They just don't possess the right decision making capacity. That's why you'll see them repeating the behaviors again and again. You need somebody who is more, who tells them what to do instead of, you need a good home environment, and sometimes they need direction. Emotional regulation is another function of ventral PFC, and all of this is interconnected. There's no one thing, but this is where the delayed gratification and the cognition comes from. How do we know this? Adults with ventral PFC dysfunction are more impulsive. They don't make the best decisions. And they have more lability. I'm going to show this video just to get the idea across. This is a pediatrician who is interviewing a teenager.
Jake?
Hi.
Oh, wait.
How about if I have you make an appointment for 2 months?
I didn't want that. Okay.
Sam. He completed the CRAFT screening tool and answered yes to the relax question. The physician has completed the physical exam.
So Jacob, everything looks very normal on your physical exam. Do you have any questions for me?
No.
I see that you filled out our alcohol and drug questionnaire. Is it okay if we go through this together?
Sure.
Okay. What we talk about is confidential. I only tell your parents about what we say if you give your permission or if I become worried about a danger to you or to someone else. Does that make sense?
Yeah.
So let's take a look. So I see that you have marked that you sometimes use alcohol and that you have used alcohol to relax, feel better about yourself, or fit in. Do you mind telling me a little bit more about your alcohol use?
It's not a big deal. Sometimes with my friends, we'll drink a few beers and when we're hanging out or when we're at a party, and sometimes rum and cokes.
Okay, so how many do you usually have at a time?
3 or 4 probably. I don't keep track.
Okay. And how often?
Probably about once or twice a month.
Okay. So you drink with friends, sort of 3 or 4 beers or mixed drinks 1 or 2 times a month. How long have you been doing that?
Probably since last October.
So for about 6 months. I'm curious, what do you like about drinking alcohol?
What do I like about it?
Yeah.
I don't know. It's just fun to drink with my friends. Like when we're at a party at someone else's house and we're drinking with other people that we don't know. It tastes good.
Okay. So it sounds like you feel relaxed and have fun when you're drinking with friends, and you like the taste.
Mm-hmm.
Okay. I'm also curious, are there any parts about your alcohol use that you don't like?
I don't like when I get sick in the mornings because of hangovers and when I start throwing up, and I don't like that.
Have you ever experienced a blackout, like when you've been drinking and you wake up and you don't remember what happened?
No, but that happened to someone I know, though.
And have you had any problems related to your drinking alcohol, like at home or school or somewhere else?
One time I missed first period at school because I had a hangover and I was late getting up. And Mom got mad at me because I wouldn't get out of bed, and she said she knew I had a hangover.
Have you told your mother that you drink with your friends?
No, but I got grounded for 2 weeks after that.
So more negative things about your drinking, like getting into trouble with your mom and missing a class at school when you had a hangover?
Yeah, but I only missed school once.
Okay. I see on the questionnaire that you have not ridden in a car with someone who's been drinking, and you haven't driven a car after you've been drinking. Is that correct?
Yeah.
That's great, and I hope you continue to avoid those things. As your doctor, I want you to know that I'm concerned about your drinking. When teens drink, things can go wrong, like injuring yourself. Even when you don't drink to excess, though, your brain is still developing and is very sensitive to the effects of alcohol.
Okay.
That's why I recommend that all my adolescent patients not drink at all. So if you were to think today about how ready you feel to stop drinking alcohol on a scale of 0 to 10, with 0 not being ready at all and 10 feeling very ready, what number would you pick?
Probably a 5.
A 5. So I'm curious, why didn't you pick a lower number like a 2 or a 3 that would mean you're only a little bit ready to stop drinking?
Well, I guess I'm just tired of getting in trouble.
Okay. What could you do to avoid getting into trouble?
Not drink?
Have you ever tried not drinking or stopping drinking?
No, not really.
What some people your age do is try stopping drinking for a period of time just to see what that feels like.
I could probably do that.
So how long do you think you could go without drinking?
I don't know.
Do you think you could go 2 months without drinking?
Yeah, probably.
What things would make it easier for you to not drink?
I could probably drink something else when my friends start drinking, like just Coke.
Anything else to make things easier for you?
I could probably hang out with some of my friends who don't drink. We're inviting them to parties and having fun, because not everyone drinks at parties.
Okay. Is there anybody in your life that you can talk to about this who'll give you some support for not drinking?
Yeah, my friends who don't drink would probably be happy that I'm not drinking either, and they'd support me.
Great. So you've come up with some reasons to stop drinking, like having hangovers and throwing up and getting into trouble. And you've developed some strategies to try to not drink, like spending more time with friends who don't drink or having non-alcoholic drinks when people around you are drinking alcohol. I think that's a great plan. I'm really proud of you for giving this a try. How about if I have you make an appointment for 2 months from now, and then I'll see you back and we can see how things are going.
Okay.
This was a good example. She probably scheduled the appointment for longer than she should have. You don't want too much space in the 2 appointments, because things could go wrong, especially with the substance abuse population. You gotta give them a couple of weeks or a month's appointment, if possible. Assessment techniques. Again, the literature shows role of reflective listening. What reflective listening means is you listen to the patient. It's more like active listening. You listen to the patient and you intervene at the right time. It could be complex or simple. Simple reflective listening would be you just kind of mirror what the patient is saying and just say the same words back. So you say drinking is a problem for you. Complex would be, it's really gotten you to this bad place in your life. When you bring up a hypothesis and you kind of say it in your mind. It's important to have open-ended questions. Again, many people think of it as taking longer, but I think of it as being more effective. Shouldn't say but it helps you extract more information. It helps you extract all the information that you need. And we don't tend to use it as much in the medical environment. Readiness to change, you gotta assess for that. Motivational enhancement therapy is something that's done by counselors, and what we need to do is basically recognize that it could be useful for this person to do that, and we refer. Some examples, you listen, you come up with a hypothesis, and you say, it's not been easy for you. That makes the patient think that you're listening to them, you care for them. Open-ended questions, an example would be, tell me about your eating patterns, tell me about your smoking. Readiness to change, again, ambivalence, you're thinking about being a supermodel, but some sort of problem they might have. You're eating comfort foods or comfort crack. Your motivational enhancement therapy is done by mental health professionals. OS is a good acronym or mnemonic. O is open-ended questions again, that tends to evoke the data. Affirmations, you want to foster the positive feelings. You don't want to put them down. You want to look for clues which, and build up their self-confidence. Reflections is, like I said, simple, could be complex. If you can't do complex, do simple. Just repeat to them what they're saying. And towards the end, summarizing helps. It reinforces the behavior change. In the third edition of MI, the principles, and you can read that, but I've come up with some things you could say. So expressing empathy, this, whatever the problem behavior is, has brought you to a scary place. Developing discrepancy, you could say something like, how does dropping out of school help with your aim of becoming whatever you want to be? You roll with resistance. You don't. An example would be, I know you feel immunization is unsafe. However, data shows blah, blah, blah. And self-efficacy, great that you've cut down on smoking, but it seems like your friend tempts you to do. How do we plan for it and let them think? Specific, engaging. You want to have the patient talk about their problem behavior more. So you could use something like, what are your concerns regarding whatever the problem behavior is? Focusing, how things could be different if you didn't have versus you did have this problem behavior. Change talk, or evoking would be on the scale of 0 to 10, how, like in that example, 0 being no motivation, 10 being the most motivation you can have. Why did you choose a 6? Why not a 2 or 3? And they would tell you, well, it does interfere with my relationship. It does interfere with, if they have chronic physical illnesses, I have to get hospitalized and it makes me feel bad. And towards the end, kind of summarizing it and planning for it, what's the first step you're willing to take? Social media or apps, they help a lot. They help the teenager to relate to you better. So if you can give them a couple of apps, they're going to do the change themselves. They're going to, something like WhatsApp, we don't know about it. It's not WhatsApp, it's a different app. It's used for the emotional dysregulation and it's useful for teenagers. I've had patients, if therapy is an issue, you just let them download this app on iPhone and let them emotionally regulate themselves. It's going to ask you, when you look at the app, it has a personal diary to it. It has how to resolve anxiety attack, how to resolve panic. Change talk is something which is useful too. Change talk, I'm going to have Dr. Stevens speak more about motivational interviewing. Change talk and sustained talk, two things we need to discuss about. Change talk is something when you see that the patient is moving towards change. Sustained talk is something which the patient gets resistant or gets defensive or just continues to say the same thing. So with change talk, you press on it more. You don't let it go. So if they're talking about they're wanting to change something, you give them help and tools to change it. Sustained talk would be something that you want to come back to later because it's not going anywhere. One of the mnemonics is DAN-CAT. It's available in the literature, which says about your desire to change, your ability. Desire would be something like, I want to do it, but ability is, what do you mean I can't do it? Then, readiness for change, and then further on. Okay. Dr. Stevens is going to be doing more talking, and then we'll have a time for discussion.
Thank you, Dr. Joshi. That was very good. There's a lot of literature out there on motivational interviewing, and I've been doing this, or trying to explore this for a while now, and I still find it hard to do. I think over time we've all become more biologically based. We tend to ask our questions that way, we tend to think that way, and we tend to treat our patients that way. We're now having to interface with a third person in the room, the computer, and that sort of makes us more a binary, yes, no type. And it's a lot of things, it's a lot of information to take at once. And I try to think about it in my own head, well, if I had to simplify it, what would that be? And I think ORS simplifies it the best. And ORS, Dr. Astik covered, in the O is for open-ended questions. You want to ask things, not just yes, no, but you want to ask things open-ended. Can you tell me about your diabetes? How's your sugar been running? What's it been like? How do you take your insulin after school? And just get the child talking to you. The A's are affirmation. So if they say something positive, or they show some ambivalence, then go with that, and tell them that I'm glad you're thinking about that, or I'm glad you've tried to do that, and reinforce the positive things. You can do R's for reflections, and you can do things like, well, it sounds like it's been hard for you to manage your diabetes. It's been hard for you to calorie count. Can you tell me some things that have worked for you? Or and S is for summary. You just summarize what at the end of your interview with the patient. You summarize what you've talked about, and the thing that you always listen to is you listen for change talk. And change talk is when the kid says something that you can hang your hat on when it comes to motivational interviewing. In motivational interviewing, these are like preparatory statements. That means the kid's thinking about making a change. And that's desire, ability, reason, and need. In other words, desire would be I want to change. Ability is I can change. Or reason, it's important to change. Or need, I should change. These are all change statements that different adolescent patients might make to you, and you want to kind of lock that down in your mind. And because some kids use reason, some kids use shoulds, some kids use wants and needs, and what you try to do is you try to be, especially if you're talking to a teenager, you want to be a guide. You don't want to be directive, because teenagers, one of the things they're striving to do is they're striving to be their own boss. But as Dr. Joshi said, the problem is their boss is not fully developed. Their prefrontal cortex doesn't really get developed till about 25. And when you think about it, I mean, that's why if people get married when they're young, you want them to have a long engagement, you want them to get advice from their family and friends, you want them to kind of go slow. The problem is with some of our patients, and I'm using diabetics right now because teenage diabetics can be very difficult. Hold on just 1 second. So you want to pay attention to where they're at, and you want to say positive statements that can help hopefully reinforce what you're trying to have happen. A lot of times, to think about all these principles of motivational interviewing is just too much. So I just say, if you're having a busy day, just list the pros and cons. If you're not taking if someone's having trouble taking their insulin shot, what are the pros for taking your insulin shot? You know, you can not get sick. You can make your parents happy. What are some of the cons about not taking your insulin shot? Well, you might get sick. You might, and sort of explore that, because sometimes there's some positive things for not taking your insulin shot. Well, you don't have to you can escape from being a sick person. It's hard to take the sick role, especially when you're at that age when all your hormones are telling you you're invincible. You know, so you want to kind of meet that teenager where they're at, and not only understand where you would like them to go, but understand where they're at. I wrote some things, some principles you might want to practice is express empathy. This diabetic problem you have is kind of scary. I'm sure you get frustrated at times. Help them develop discrepancy. A lot of times they don't have much discrepancy. How is not taking your insulin working out for you? You know, how does counting calories, how does that help you? The biggest thing, if you want to take anything away from the talk at all, is to roll with the resistance. When you're talking to a teenage patient, they're going to have all kinds of thoughts and feelings, and some of them are going to be the antithesis of what you're trying to accomplish. And just roll with it. Just acknowledge it, acknowledge how they feel, their feelings are real, and try to guide them into a safer place. And anytime they anytime they bring up something that they're doing well, be supportive. You can tell them, you're the best one to know how you feel. You're the best one to know how many calories you ate. You're the best one to be able to plan out your exercise. And there's a lot of different things you can do now. Dr. Astik talked about some of the things that they have apps. But they also have apps for calorie counting, for exercise, and to help you regulate your diabetes. And almost any teenager is better at using their phone than I am, and using a computer. But they have phones, so you can do the calories counting and everything from a watch that's connected to your phone. Always remember to address high-risk behavior. If they're doing something dangerous, find a way to talk about that that's not alienating the teenager, but it's addressing your concerns. Use any kind of clues they give you. And if you can't, and all these things are at times difficult. I know when I'm at the end of my day, I'm pretty much in my con box. I'm not very pro. So if I can't do anything else with that teenager, I just listen. Just stop and listen. If you can do that, that'll reinforce the relationship you have with the teenager, and then hopefully you can get to a better place. All right. Any questions? And one of the issues the adolescents have is very often taking medicine means there's something wrong with me. And there's a lot of psychodynamics in that, without getting too complicated, but I mean, you're asking them to take something, put them in their mouth, and ingest it, and they don't want to do that. That is the last thing they want to do, is ingest these pills that you're giving them. So you have to sit down and listen to some of their talk if you can, and then somehow figure out a way for them to be in charge. Well, if you were to take your pills, let's say you're getting it, well, what would be the best way? How use something easy like ADHD medicine. Well, if you're going to take your medicine, ADHD medicine, how would you like to take it? Would you like to take it when you get up? Would you like to take it with breakfast? When you brush your teeth? What would be the easiest? What do you think might be the easiest way for you to do that? And then you try to do something like that doctor on the video did. You try to come up with a treatment plan that that you get in the child's words. So, taking your pills after you brush your teeth, you think that'd be a good idea? Well, let's do it that way. I'm not saying this is easy. It's very hard. It's very frustrating. And what you're saying is very real. People, you tell them how to take their medicines and they don't do it.
Give them some way that they think they are in charge of it.
Yeah, try to hook them into it somehow. Try to be a salesman.
And many times we get caught up in I don't like the taste, I don't like this, I don't like that. It's important to stay professional and not get. But
Don't take their anger on or their frustration at you. It's not as my daughter would tell me, Dad, it's not about you. You know, it's, you know.
I think I also learned from that experience that the patient was given a input medicine starting from another facility, and then she continued with the clinic. I agreed, okay, that she takes input, I assume she can't follow the bill.
Yeah.
So when I got to know from child, I went after the patient and said, let's try tablets because
Yeah.
that's not giving that aftertaste that you're having.
Yeah, yeah.
So, and
that's the problem
yeah, what was hurting me that it took her 3 visits to 4 visits to tell me.
Yeah.
That's the problem. She's not taking her medication.
Yeah.
And that's the problem with chronic physical illness. You're taking something which doesn't affect you. We know the literature. They don't. They're thinking about that day. Diabetes, epilepsy, why am I taking this?
It sounds like
Doesn't make sense to them.
It sounds like you found out why she was having the problem. In some diet, like for instance, you said the taste or the pill or the shape or the form it comes in or the time. For us, it might be, well, what does it matter? But for them, it's everything. Yeah. Those patients, that patient you're talking about, it's very real, and it's hard. And sometimes, if I can and I have the time, I try to explore that. You're tired. Tell me about that, and see if if they can't talk and express what that is. You know, when a young teenage female tells me they're tired or they hurt, that covers so much stuff. I don't know what it is they're talking about. So if they can talk about it, sometimes each individual case is different, but you have to figure out what that is. What do you mean by you're tired? You know what I mean? She doesn't want to do it.
Basically, she just said, I don't want to do it. Like, I don't want to check my blood sugar. She is a glucose monitor.
Right.
She's actually a very good adjunct to her therapy. She doesn't want to wear that. She just is very disinterested in her care.
Yeah, that's very hard, and sometimes you can. There's no good way. I've used different things with different people. Sometimes I use somebody they know. In the old days, I used Mary Tyler Moore because she was a diabetic and she was a good actress, and a lot of women would know her. But teenagers, they have no idea. So I try to find somebody out there that's a diabetic, that's doing a good job with themselves, that they recognize, an athlete or something like that. That's one way to do it. Another way is to find out what are their goals, what would they like, is anything they would like, and how is controlling their blood sugar going to help them get to that goal. That's one way to do it. It's not easy, and I don't want to mean to say it's easy to do.
Stressing on them being tired and finding out what that means to them is going to help with the therapeutic alive.
Because what you're talking about is somebody that's in the pre-contemplation phase. They're not even contemplating doing what you're telling them. So that's very difficult to get them from pre-contemplation to contemplation. So what I do is try to explore, try to create some dissonance, and with a teenager, you want to explore any ambivalence they have. I hear that you're very tired, it's very difficult to do this. Is there anything that would make you want to do this? Just try to, if you can, and you may not be able to do this in one visit, is start getting that ambivalence there. You know, that's what I mean by guiding them. You kind of push them, nudge them, push them a little bit, not direct, not where they feel like they're not in control. Well, sometimes what you have to do is I have to separate them. I have to separate the parents and the child. And the other thing you could do is, Dr. Joshi mentioned in his talk, sometimes he talked about referring them to motivational interviewing, but if you don't have that available, just refer them to therapy. Maybe another place where they can establish a relationship with somebody over time, because sometimes you don't have the time to be able to create a safe place for that teenager to deal with her emotions, but they probably need it. So if they had a therapist they could see, maybe they could talk to their therapist and start building up, taking down some bricks out of that wall, building up some ambivalence, maybe getting into maybe getting into contemplation. You know what I'm saying? So when they see you, maybe you can go further. How old is she? Yeah, then I would probably definitely want to get her into therapy with somebody, because she needs to individuate from her mom or her family or whatever. She needs to individuate and then go back and take control. And all that's fine to say, but you got to make it happen. So, because otherwise you're going to get, you'll never get out of that conflict. And she set up her independence by not doing what you, the doctor, tell her. And that's not going to work. She needs to start being an adult.